Okay, well, we're here with Dr. Sarah Rutherford to talk a little bit about some of the data that she's presenting alongside her colleagues at the American Society of Oncology. Sarah, welcome to the Hem-Onc Pulse and Blood Cancers today. Just a little bit for our viewers, where do you practice and what's the scope of your work?
I practice at Weill Cornell Medicine in New York, and I focus in clinical care and research in lymphomas.
Yeah, so that's great. You know, a lot of the, from a lymphoma standpoint, we do a lot of testing on patients, from bone marrow biopsies to PET scans and CAT scans. I think it goes without saying, excuse me, that sometimes we probably overdo it, maybe sometimes we underdo it. I'm curious your thoughts about this because I know that you really are interested in this and you presented some data that we can hopefully minimize some of the too much testing that we do.
Right. I definitely agree on trying to simplify clinical trials in lymphomas. I've done some work with the Alliance for Clinical Trials looking at bone marrow biopsies in follicular lymphoma clinical trials, and we also included some SWOG and ECOG studies in that, which was published earlier this year in 2023. And we showed that bone marrow biopsies were irrelevant for response assessment for most patients with follicular lymphoma on trials, and we advocate to eliminate them from clinical trial requirements. And it goes without saying that these procedures can be painful, they're costly, and they cause anxiety for patients. So the natural next test to look at, from my standpoint, was imaging. So both in clinical practice and in clinical trials, imaging is done quite frequently, and it has a lot of negative aspects to it. So radiation exposure, potential for secondary malignancies, very anxiety provoking for patients, and then of course cost. And so what we did in this study is looking at 5 of the clinical trials from Alliance that were conducted from 2008 to 2016 in patients with untreated follicular lymphoma. We assessed the progression-free survival, which is a common primary endpoint in follicular lymphoma clinical trials, based on the imaging that was required by the trials versus looking at every other scan. So we omitted every other scan and did a progression-free survival analysis. And we found that there was a very minimal difference in the 2-year and 4-year progression-free survival when we just looked at every other scan. And then we actually also did this simulation study, because obviously these are relatively small trials. So we did a simulation study looking at 100 observations of 1,000 different scenarios, basically, that in which we found similar results. We looked at 2 different clinical trials and we found the similar results. So basically simulating a much larger amount of patients where the progression-free survival was not that different at the time points that I had mentioned before. So essentially I'm recommending that we try to eliminate a lot of the scans done in the clinical trial setting for all the reasons that I've alluded to.
I think from a practical level, this is amazing, right? I mean, you're reducing costs, reducing the anxiety, all of this thing. How do you advocate from a clinical trial perspective? Because you have like few hoops to go over from regulatory stuff and other things. Like, how do you get to where you want to get?
Right. Well, I do want to say that I think this, for the whole group of us that are doing clinical trials, and that includes the pharmaceutical companies, it includes the National Clinical Trials Network, and all of us doing investigator-initiated trials, that trials are very expensive to run, and in the interest of our patients, I think if we can make the trials we have cheaper, then we're going to be able to offer more trials for the patient. So just on like a quick scratch pad that I was looking last night based on old numbers for CT scans cost, I think that this would save at least $40,000 per patient, probably more depending on the trial and how many scans were done. So if you think of that, times all the different people on those trials, it's very clear cut. Even if all the other, positive aspects of this were not met, even just the cost alone is important. So I do agree. I mean, I think looking at a larger data set would be helpful. I do think that there are some steps to take, but I think I've talked about this to a lot of people, and everyone, whatever their role is, is in agreement with this type of strategy.
So the tougher question I have for you is that changing behavior is tough.
Right.
And physicians and practitioners are creatures of habit, right?
Right.
We all are. So the clinical trial, I can see more miles you're able to maybe change that because you can put the guidelines.
Right.
Do you have any plans how you actually transmit this to the real world where, you know, an oncologist who's used to doing a bone marrow biopsy, used to doing a CAT scan every 3 months,
Right.
how are we gonna then change that behavior?
It's actually a great question. So particularly for diffuse large B-cell lymphoma, there were some
And
recommendations.
just to clarify, your data is on follicular and diffuse large? Or?
Data is just on follicular lymphoma, but I think the same principles apply to different types of lymphoma as well. So to provide some background information, in I think it was 2013, so 10 years ago, that ASH and the American Board of Internal Medicine have this campaign called Choosing Wisely, in which they're trying to advocate for, you know, more patient-focused, cost, you know, favorable type strategies. And one of theirs was to actually limit CT scans imaging in patients with diffuse large B-cell lymphoma who were in complete response after undergoing treatment. And so I actually had just found some data recently to suggest that though in the last 10 years since that surveillance scanning has gone down, it's still quite prevalent. And I think it actually takes, and I know we're very busy as clinicians, but I think it takes a lot of work as clinicians to say, you know, I actually feel comfortable not scanning you, but we need to keep in touch. You need to see me every 3 months at first, and we can space it out later. You need to let me know, to the patient, you need to let me know if any new symptoms come up. And I think it's actually, you know, very much more patient-tailored approach. So I think continuing to talk about this, and honestly making some of the physicians who may take care of lots of disease and maybe don't know all of the sort of evolving criteria, you know, with support and guidance, they may feel more comfortable starting to do scans less frequently.
Well, I think every
overall.
patient is going to thank you, because one less bone marrow biopsy is less pain and less discomfort, and the anxiety point that you hit on is so true. Dr. Sarah Rutherford, thank you so much for joining us on the Hem-Onc Pulse Blood Cancers today. Congrats on the beautiful work, and look forward to catching up with you again.
Thank you. I enjoyed it.